السلام عليكم. مساء الخير. نرحب بكم on behalf of the Arab Thyroid Association Board of Directors as well as the webinar committee. It gives me special pleasure to welcome you all to this educational session as part of the Thyroid Update series. Tonight, we will have a special theme on thyroid autoimmunity as well as thyroid eye disease. We have a couple of excellent speakers. We will actually have our first speaker, Dr. Nada bin Hariz from United Arab Emirates, Al Ain and Tawam Hospital. And also we have Dr. Amjad Hamad from Albany College of Medicine in US. The first presentation will be delivered by Dr. Nada bin Hariz. Nada is a colleague from Tawam Hospital. She qualified from the Al Ain University, and then she went for her fellowship in Canada, where she trained in Ottawa, and she has a special interest in thyroidology as well as lipidology. She has also a dedicated service in thyroid cancer. Tonight, she will give us a talk about thyroid autoimmunity, Hashimoto and Graves, and beyond. Dr. Nada bin Hariz, the platform is yours.
You see my screen? Doctor, it's okay?
It is not appearing yet. I think they will help you. Just if you could just make screen share.
I will share again. Just a minute.
Yes, here we are. Yes. Go ahead. It's all ready.
It's clear now?
Yes, it is clear. Go ahead,
Okay.
Dr. Nada.
Good evening, everyone, and thank you, Dr. Tariq, for the kind introduction. Today, I will discuss thyroid autoimmunity with particular focus on Hashimoto and Graves' disease, but from a slightly different perspective. Rather than revising what we already know, I will focus on how our understanding is evolving, moving from traditional concept toward a more precise, clinically relevant approach. In particular, I will highlight recent advances in disease mechanism and, more importantly, how these are beginnings to influence real clinical decision making. And through the talk, I will try to keep the focus on what this means for us in daily practice. So nothing to disclose. Let me start by briefly framing how I will approach this topic. I will begin by step back, as I said, and look what we currently understand about autoimmune thyroid disease, then move into what has changed, particularly in terms of disease biology and immune regulations. And finally, I will focus on how this translates into clinical decision making in our daily practice. So, if we step back and look at thyroid autoimmunity over time, our understanding has clearly evolved. Traditionally, we approach this as antibody-driven disease. We measure antibodies, made the diagnosis, and focus primarily on correcting thyroid hormone abnormalities. But what is increasingly recognized now is that this is not simply an antibody-mediated process. It is complex immune network disease involving T cell, B cell, cytokine signal, and broader immune regulations. And this shift is important because it's fundamentally changed how we think about management, and direction of the field is toward more precise immune modulation, not just correcting thyroid hormone level, but targeting the underlying disease process. So this is not just change in the treatments, it's change in how we understand the disease itself And with that in mind, I will briefly review what we currently know before moving into what has changed in the recent year. So what we know, all of us know that autoimmune disease is not a single event. It's a staged immunological process. It's began with susceptibility program or progress to loss of tolerance and ultimately result in immune activation and clinical disease. So let us start with genetic susceptibility and environmental triggers. And in the first step, genetic susceptibility is autoimmune disease develop in individual with genetic predisposition. Particularly, we know those are the genes which involve. This gene regulate the immune balance, which it is T cell, B cell, and it's lead to lower the threshold for T cell activation and impair regulatory T cell function. As a result, the immune system became more reactive with increased B cell activation. This lead to increased recognition of thyroid antigen, particularly or particular TPO and thyroglobulin antibodies. So immune tolerance is still preserved here at this stage. So nothing happened to immune tolerance, but it is the susceptibilities, not the disease. And that's why we know that genetic does not cause disease, but it creates vulnerabilities, and the people or the patient become more pronounced to get the disease. So genetic alone is not enough, but this vulnerability need to as a triggers. So what triggers we know? These triggers act directly onto immune system. Either it's environmental, microorganism, and also it's enhanced, include like affecting the T cell, B cell, and antigen presenting cell. They also enhance cytokine signaling and inflammatory pathway. This result in shift toward immune activation. And then here is the point where loss of immune tolerance. So many trigger is there, as we know also this all list and the drugs which can cause as a major trigger, which we saw it day to day in our daily practice. Then this is now considered the central step in disease initiations where there is loss of immune tolerance. And before we talk about the disease, we need to understand how the immune system normally prevent autoimmunity. This process rely on two key layers, central tolerance and peripheral tolerance. So top here you can see that T cell originate or usually produced from the bone marrow and mature in the thymus. And then it will go to the thymus where it's get mature there. Self-reactive T cell are eliminated here. So if there is any problem with the antigen, it will end here and will eliminate. This is a central tolerance. Any cell that escape, as you see here, it escape from this phenomena and are controlled in the peripherally, where here is in the peripherally another story where regulating of the T cell, usually regulatory T cell actively suppress inappropriate immune response if it is normal. So under normal condition, the immune system is tightly regulated and self-tolerance is maintained. But what's happened when this system fail? So we're here where this system fail after all this genetics and what we talk about it. So breakdown of peripheral and central immune tolerance happen, and where the immune activation is a start. And this is here where T cell activations can cause cellular immunity and mainly CD8 T cell, and its drive for inflammation and direct thyroid injury by T cell, while B cell, we know that it's mainly produce antibodies. And the key antibodies we see in clinical scenario, TPO and thyroglobulin and TRAB antibody. So inflammation and antibody work together but with different role for each of them. And now let's connect all of this into one clinical pathway. So in this full disease model, you can see that this integrate everything we discuss. So initially, you can see often the environmental trigger lead to antigen release and antigen presentation in the lymph node, activate of T cell and B cell, and this where the tolerance break down, and finally immune cell infiltrate the thyroid, leading to cytotoxicity and apoptosis. So this is not a single event, it's a progressive multi-step immune process. And depending on how this immune response is expressed, we see different clinical phenotype. Hashimoto, we can see grape disease or thyroid eye disease, and it can depends on its penetration, depends on clinical phenotype where each presentation will happen. So this is what we know. So what is the new about the mechanism? So over the past few years, our understanding, which I already showed to you, or which all of us we know, we are moving away from this simplistic antibodies-centered view toward more integrated model of immune dysregulation. So the disease itself has not changed, our understanding of it has. So what exactly has been changed? Now we have a new concept or more understanding of T regulator dysfunction and immune imbalance, cytokine-driven inflammation, and more important, there's a lot of expert publication about gut thyroid axis emergings. So not it's only antibody driven, as we say, but it's dynamic immune behavior. And we can speak more about the gut thyroid axis, which it is nowadays there's a lot of maybe reading about dysbiosis, which has been associated with autoimmune thyroid disease. And that's highlighting the important concept or new emerging concept about interaction between environmental and immune regulation. So the thyroid is not isolated by itself, but it is a part of broader immune environmental network. And you can see here it starts with genetic susceptibilities and environmental trigger, leading to immune dysregulations, particularly imbalance between T regulators, which we already spoke about. This activates cytokine, then drive B cell activation and autoimmunity production, and ultimately result in different clinical phenotype, Hashimoto. But here again, the gut microbiome playing a big role of induce immune activation, and that's give us same antibody does not give you same disease. Variable clinical phenotype can happen, fluctuating disease course usually, which we are seeing nowadays. This evolving understanding is not just theoretical, it's fundamental change how we approach autoimmune thyroid disease in clinical practice. First, we need to move beyond simple antibody-based labeling, because antibody alone do not reflect disease behavior if you label it only by checking the antibody. Second, we need to integrate the full clinical context and including symptom, thyroid function, disease trajectory over time. We must recognize that autoimmune thyroid disease, it's a heterogeneous disease, and it is a spectrum. There are different immune pathway, not single uniform, and management should be individualized rather than applying a one-size-fit-all approach. This is why autoimmune thyroid disease should be viewed, as I said, as a spectrum rather than a single disease. But important question is here, do we actually see this spectrum reflect in the real world population, particularly in our region? Let's look at the available data from the Arab population, but how does this conceptual model translate at the population level? So in this table, I try to summarize the key study from across Arab population, including UAE, Saudi Arabia, Kuwait, Jordan, and Qatar. I would like to highlight the consistent pattern across them, as you can see here in the rate of anti-TPO. And also there is a strong family predominance and highly burden of subclinical disease. And you can see here that in our population, the diseases start early, and that may be let us to look more for early screening. And so if we take a step further and compare our regional data to global population, we start to see broader pattern. And first, you can see here at antibody prevalence, we see that it's broadly comparables across the region, suggesting that the underlying autoimmune process is similar between both Arab regions and non-Arab regions. However, when we look at hypothyroidism prevalence, we see slightly higher burden in Arab population compared to Western populations. And we also can see that there is an earlier disease onset in the age. And that's you can see that the age here in Arab population start 30 to 40 years, while in the Western population 40 to 60 years. And the subclinical disease is common across the all continents. So it's almost we can see that disease trend to start earlier, as I said, whereas we can reflect this change or while we have this spectrum is primarily expressed in two major phenotypes, in Hashimoto or in Graves' disease. So this is mainly for all autoimmune thyroid disease. So although both conditions, if I will speak about Hashimoto or Graves' disease, share a common autoimmune origin, they represent two fundamental different immune mechanisms. And in Hashimoto, the immune response is predominantly destructive, leading to gradual thyroid failure and hypothyroidism. And you can, as we explained already, I don't want to repeat that, but we can see that the TPO antibody or anti-TPO and anti-thyroglobulin antibody are the marker, but not necessarily the primary drivers, as I said. But the opposite in Graves' disease, where it is stimulatory autoimmune process, when TSH receptor antibody directly activate the gland, lead to hyperthyroidism, and once destroy the glands, and another one is overstimulate the glands. So what we know, it's common autoimmune origins, female predominant, genetic environmental, antibodies central to diagnosis, and predictable biochemical patterns. And as we see that it can share the same starting points, and what is emerging now and what is the new now, it is as we focus in this talk, it is an autoimmune is not a single entity, but rather it is a spectrum, and this is being emphasized and in all new journals. And so again, more speaking in all literature about immune dysregulation, about T regulation dysfunction, cytokine, and loss of immune control. And this reflects dysregulation of immune control, and that it's the fundamental autoimmune is a failure of regulation, not just antibody production as we are understanding it before, but it is about all autoimmune system, and it's more complex than what we thought. One of the most important paradigm shift, as we said, it's antibodies, and that's why explain why some patient biochemical euthyroidism does not mean clinical euthyroidism. even if both of them have negative TRAP, for example, but maybe both of them, they feel different and completely different in terms of clinical symptoms, because it's not just an antibody, it's complex immune system. One of the most relevant clinical implication is mismatch, as we said, between a biochemical and clinical status. And we often see the patient, as we said, with normal TSH plus resistant symptoms. And that's, again, it's all, usually I explain to my patient, because it's not about normalization of your lab, but it's all about what the immune system, which it is hard, we don't have a marker for it, how it's become normalized again. And now moving from mechanism into clinical practice, and this is another point, this very common scenario where you have elevated TSH and normal T4, and we think about, we stratified based on the three main factors, not only the TSH level as before, when TSH above 10 in subclinical hypothyroidism, we start the disease when it is less than 10, but nowadays we are more speaking about also symptoms beside TSH. So number 2 is symptom and patient-specific risk factors, including age and antibody status. So it's not only one entity where you will be build on it the decision of a treatment, but it's all about all entity together, TSH, symptoms, and patient-specific risk factors. And what is also new now, the more speaking about TRAP predict, is not only it is a biochemical marker, but it is also predict relapse, treatment response, and pregnancy risk. And we can see here the figure which demonstrate the relation between the TRAP level and the relapse risk. And patient, you can see patient with higher TRAP level have significantly higher recurrence rate, reaching up to 60 to 80%. In contrast, patient with low or negative TRAP antibodies have a much lower risk of relapse. So TRAP help us identify how is suitable for stopping the therapy and how may require definitive, and who may require definitive therapy. And beyond prediction, let's look at behavior during the treatments. So TRAP does not follow a simple linear patterns. In some patients, TRAP decline and remain negative, and these patients have a high likelihood of sustained remission. But in another, you can see in the figure, TRAP fluctuate or remain positive, and this is associated with relapse rate of around 40 to 60%. So during antithyroid therapy, it is the trend, not a single value you need to rely on, but it is a trend of the TRAP antibody that's guide our decision making nowadays. And after definitive therapy, the pattern change following radioactive iodine. You can see TRAP may initially increase due to antigen release. However, in patient who responds, TRAP level progressively decline over time. And that's opposite to persistence elevation, which suggesting ongoing autoimmunity activity and possible treatment failure. So again, TRAP reflect the underlying immune process across different phases. And this translates directly into clinical outcome. Second, after radioactive iodine therapy, has a higher remission rate and faster response compared to the first. This likely reflects both patient selection and underlying disease biology. So understanding disease behavior and thinking about the timing allow us for better plan for treatment strategy. So how do we translate all this evidence into practice? This table here, I summarize the clinical utility of TRAP, and we can, that's what we already talk about. It can give us, there is a lot of evidence nowadays for relapse predictions, treatment response, and pregnancy risk. But not all antibody behave the same. Thyroglobulin antibody reflect immune activity, but its clinical utility is fundamentally different than what we saw in TRAB. In Hashimoto thyroiditis, it supports the diagnosis and may indicate risk of progression of disease. How when we look to the Hashimoto thyroiditis patient, while thyroglobulin antibody in grave disease, it reflects coexistence autoimmunity, but does not it's reliable predict of relapse. So even dynamic change may provide some insight, but this is not yet part of routine decision making. This is here again speaking about each phenotype reflect different mechanism, and in thyroiditis, clinically, when there is a patient presents, they don't came labeled as subacute or postpartum thyroiditis. They present with thyrotoxicosis first. So the key clinical question is not the subtype, it's the mechanism. So all of them will present the same, will present as hyperthyroidism. It is destructive or true hormone protection. This is the question where you need to ask yourself, because when you know the difference between each phenotype, you can expect how this disease will progress and how it will relapse. In thyrotoxicosis, once a patient presents with thyrotoxicosis, we shift from naming the disease to understand. Again, the same, you need to understand the mechanism. You need to know what you are dealing with. So, and this is, I summarize here the difference between both thyroiditis and grave disease in terms of mechanism, hormone, the treatments, the marker, and the lab, and even the clinical presentations. And that all what we already know. And let us move here, because of sake of time, to the, this is a natural history of treatment response, where you can see the response of therapy for patients, and it's different between both group. And some of it still have prediction of relapse is limited data in thyroiditis. For example, while we have good data about TRAB level, goiter size, and smoking to give us a predictor of relapse. So age as a modifier, this is here just to show that not all TSH is the same, or there's elevations. We need to consider the age difference. So mild elevation may be physiological and acceptable, and the risk of overdiagnosis in elderly is very risky. So this figure is derived from population-based data, where demonstrating a clear rightward shift in the TSH distribution with age. So you can see here that in age of, for example, let us see that 6 to 8, in age of 80% is acceptable, and it can reach up to 12, but this is the median. So prediction of outcome in the thyroiditis, unlike grave disease where relapse prediction is biomarker driven, but in thyroiditis outcome prediction is primarily subtype driven. So that's why it's very important to know the subtype. Antibodies like TPO help predict hypothyroidism, but they do not predict recurrence of thyrotoxicosis. For example, here in postpartum thyroiditis, recurrence in subsequent pregnancy, it's around 40 to 70%. And this all is supported with data, how we know about prediction in thyroiditis. So what's the new about thyroiditis? Now, when we talk about this, it's important to distinguish between what is truly new and what represent evolving reinforcements of existing concepts. So maybe it's not a new, but it's reinforcements. For example, we recognize emerging triggers such as post-viral. This is something new now in the literature. And immune-related thyroiditis, a lot of research and data about it, and recognize triggers, that it is one of the important triggers, clear biphasic course, not triphasic course, and it is considered in recent infection. We also the new things about immune-related thyroiditis, which it has become more stronger in most of the literatures. So what new in grave disease? Unlike some area, grave disease has not had completely new guidelines, but the field has clearly evolved through the accumulated evidence, not a single breakthrough. So there is long-term outcome data and TRAP-based risk stratification, patient-centered decision-making, and it is shift from uniform to individualized care. Shift toward long-term anti-thyroid drug therapy now. Long-term low-dose methimazole increasingly accepted. Remission improve with prolonged therapy. So nowadays, up to 3 to 5 years data of treatment with anti-thyroid medication, it's improved the remission, reduce relapse compared to short course treatment. So nowadays, trend more toward longer duration with anti-thyroids, now a valid alternative to early definitive therapy. So individual decision making, treatment selection based on, as we know, TRAP, goiter size, age and comorbidity, pregnancy planning, and patient preference. So again, one size fit all approach is no longer appropriate. Improve relapse prediction. Nowadays, we have more prediction models, clinical and biologicals, and we can know about it based on TRAB level. So it is strongest predictors, resistance positivities of TRAB, high relapse risk, large goiter, and smoking as additional risk for relapse. Re-evolvings of block and replace strategy in the latest 25 and 26 publications, not first line in most patients, may be used in selected case, poor control, adherent issue. Now used more selectively, not like before. Emerging immune targeting strategy, targeting autoimmune pathway beyond conventional, and either using drug or radioactive iodine or surgery. Adjunct immunomodulations, which it is emerging evidence, more publication about methotrexate and combination with the methimazole in grave disease, which reduce TRAB level and increase remission potential. And that is promising, but not in any latest guidelines practice yet. So to go at the end for the take-home message, autoimmune thyroid disease is fundamentally an immune-mediated disease, not just hormonal disorder. Thyroiditis is not always self-limited, require risk stratification and follow-up. Subtype is matter in more than biomarker in thyroiditis. If you see that table, I was mentioning each subtype, what it's indicate or what's the outcome prediction. Grave disease management is shifting toward individualization, long-term strategy. TRAP is central. Diagnosis, relapse prediction, and treatment durations guidance, which is a new. One size fit all approach is no longer appropriate in autoimmune thyroid disease. Emerging therapy target immune mechanism but are not yet standard of care. Future direction about a new medicine, integrated clinical and immunological profiling. And in the past, control thyroid hormone, now understand immune drivers, and future looking for target disease pathway. Thank you.
شكرا جزيلا دكتورة ندى for such a very comprehensive and wonderful presentation. Just to remind the audience that we will be holding the actually our annual Arab Thyroid Association Congress, which is going to be virtual. This is going to be the weekend of the 10th and the 11th of October. So it is just under 2 weeks away from now. And there is going to be a special actually rate for discount for registration for this Congress. And already actually the invitation has gone out in various social media. So you have to look out for that. On behalf of the webinar committee, as well as the board of directors of the Arab Thyroid Association, I would like to thank Dr. Nada for such excellent presentation. And we will have our next actual speaker. And here it gives me special pleasure to welcome my colleague, Dr. Munzir Moumini from Jordan, who is my co-host, and he will be presenting the next speaker, Dr. Amjad Hamad. Here the special offer for the forthcoming Congress of the 5th Arab Thyroid Association meeting, which is due to actually take place on the 10th and the 11th of April. The discount of 20% from the registration fees, the deadline actually is tonight. It's only 5 hours left. So you have to hurry up. Dr. Munzir Moumini from Jordan, the floor is yours. تفضل.
Thank you very much. شكرا جزيلا. Thank you, Dr. Tariq. Thank you, Dr. Nada. Dear colleagues, it gives me great pleasure to introduce the next speaker, a very good friend of mine and colleague, Dr. Amjad Hamad. Dr. Amjad is a board-certified ophthalmologist trained in the U.S. As residency and subspecialty. And it gives me great pleasure again to introduce him to the next talk. He'll be presenting new therapeutic approaches in thyroid eye disease. Dr. Amjad, تفضل.
الله يزيد فضلك يسلم وشكرا جزيلا دكتور منذر. دكتور طارق يعطيكم الف عافيه ان شاء الله. We just heard a beautiful presentation by Dr. Nada. I will try to match her inshallah if I can. I'm going to go ahead and share my slides and let me know if you can see it. Okay.
تمام 100%.
يعطيكم العافية. So I'm honored to join you. This is my second time talking to endocrinologists in the Middle East in the last couple of years. Dr. Munder invited me to a conference in Jordan, and now I'm here speaking virtually to you guys. This topic is of extreme interest, of course, to endocrinology, and this is becoming more and more of a team approach. Treating thyroid eye disease is not just one specialty, it's multiple specialties. Ophthalmology plays a big role in this, and as well, of course, as endocrinology. And we have other specialties, immunologists being involved, and care teams, including infusion centers. My talk is mainly going to concentrate on the team approach, and it's going to concentrate mainly on practical take-home measures as how to approach a thyroid patient that comes in with eye symptoms, and when is it appropriate to refer, and how to approach from the viewpoint of the endocrinologist. So why this matters? Up to 50% of patients with Graves' disease will develop some thyroid eye disease symptoms. About 10 to 20% of those will be clinically significant. So there will be some symptoms, but clinical significance is a smaller percentage, but still 10 to 20% is a large number. During that acute inflammatory phase, we have a window. We have a window of treatment to try to modulate or help with the inflammatory sequelae before fibrosis sets in. Once you have fibrosis and scarring, the best intervention often will not fully restore the functionality of the visual system in the eyes. Out of those 10 to 20%, 3 to 5% will progress to sight-threatening disease. Sight-threatening disease can lead to permanent vision loss, and this is a crisis, is a medical emergency. The endocrinologist is very often the first physician they see, and they complain about those eye symptoms, or they don't complain about. You have to elicit those eye symptoms. The most severe end stage of thyroid eye disease is this thyroid optic neuropathy. It is a preventable condition, but only if recognized and referred to the appropriate team before it causes this permanent vision loss. This is a questions that have to be asked for every Graves patient that walks into your clinic. You have to ask about pain and pressure. Do not wait for the patient to volunteer. You ask directly. Ask them, are they complaining of dryness in their eyes? Do they have excess tearing? Is light becoming more of a problem? Are they being more sensitive? You have to ask about double vision. It may not be there all the time. It might be intermittent, comes every now and then, or might only occur when they move their eyes or their face in a certain direction. You have to elicit that. And always ask them about appearance changes. Are the eyes bulging? Or if they don't notice bulging, do they notice that one eye looks different from the other appearance-wise? They will often tell you the right eye or the left eye is a little bit larger, a little bit smaller. And that is a hint that there's some swelling happening in the orbital space. And always ask separately from all this stuff, any change in the vision. And if you have a visual change, check the cornea. Because if the cornea looks good, the surface of the eye looks good to you just by visualizing it, then a visual change might mean that they have a start of an optic neuropathy. And this, as I said, is an emergency. The key rule here is pain and double vision is active disease. And if you have it, that needs to be referred promptly. This is not a, let me get you in and see your ophthalmologist when we can get you in. This is an immediate same day or 24-hour referral. Pain and double vision in a patient with Graves' disease is an emergency. So the exam, if you want to do a quick eye exam, we're talking about 15 to 20 seconds in the office. Have them look straight at their eyes and see if there's any lid retraction. And the lid retraction is the most common sign of thyroid eye disease, where the sclera, you can see white above the limbus, above the top of the cornea, when they're just looking straight ahead. Have them move their eyes, look up and down. If the eyelid lags, as the eye comes down, the eyelid should come down with it appropriately. If the eye comes down and the eyelid lags behind it, that's a sign of thyroid eye disease. If there's redness in the conjunctiva, there's swelling, chemosis, sign of thyroid eye disease. Look at the eyelids, look at the skin around in the periorbital area. If you see edema or swelling, that could very well signify thyroid eye disease. And of course, check if there's any protrusion, see if there's any asymmetry in either eye. This is often the earliest clue. And if you do have asymmetry in the eyes and the way they look, you have to assume thyroid eye disease. So what you need, thyroid eye disease is classified into two big major buckets. Once you know this thyroid eye disease, the question then becomes, is this active or inactive? Active means you're in the inflammatory phase. This is the phase in which you can treat and adjust and modulate the disease. If there's pain, redness, swelling, all cardinal signs of inflammation, or the patient says that there's been change, or you've noticed change, you've been following up the patient, you notice change in the appearance of the eye over weeks to months, and you can go through the clinical activity score of anything above or equal to 3 out of the 7 score, then that means you're in the active phase. Active phase is a referral to an ophthalmologist for treatment to be initiated to prevent permanent damage. Now, if they are in the inactive stage, which often happens once the disease was what we call burned out, we are in the fibrotic phase. There's no pain, there's no spontaneous redness, and they've had over 6 months of no change in the appearance of their eyes, and their activity score is below 3. That means their inflammatory treatment for the inflammatory phase will not impact this patient, most likely. And we're talking about surgery to try to rehab the patient. They may still have significant proptosis. They may still have significant double vision. That doesn't mean that they're inactive. That may be just from the fibrosis and the scarring. But this is now surgical. It's no longer a medical treatment. Every patient that has thyroid eye disease needs to be classified into one of these 3 categories. And this is the most critical thing you need to do, because if you misclassify, you will mismanage those patients. The mild is lid retraction. That's minimal, less than 2 millimeters. Very soft tissue signs, no impact in daily activities. These you keep in your office. You monitor them closely. You do local measures, artificial tears, maybe tape their eyelids. And in a selected patients that have selenium deficiency, there has been reports that selenium may help with those patients. But you have to keep reassessing them at every 3 to 6 months. Any changes in their symptoms or signs, you will reclassify. The next one is moderate to severe, which is more lid retraction, more proptosis, significant any double vision, significant swelling, and functional impact on life. Those have to be treated now. We don't. It's not a wait and watch for those patients, and there are treatments that we will discuss. Now, the third and the most serious bucket is this: do they have a sight-threatening thyroid eye disease? And like we said, this is an immediate referral, same day or 24 hours. If they have symptoms of dysthyroid optic neuropathy, severe corneal exposure or ulceration, send them out immediately. These are the red flags that mean that they are vision threatening. Decreased visual acuity, same day ophthalmology. Color vision changes, same day ophthalmology. A relative afferent pupillary defect, you check with a light, swinging back and forth from one pupil to another, and the pupils don't stay down. One of the pupils starts dilating, even though the light is shining in it, same day ophthalmology. If you can check their visual fields, a rough exam with checking fingers in the periphery, and they have a defect in either one of their eyes, that means a sign of optic neuropathy. And if they have severe pain and they complain of rapid changes in their eyes, or you look at the front of their eyes and you see exposure keratopathy, haziness in the cornea, then you need to send them immediately to the ophthalmologist. This is no longer a routine disease. The endocrinologist's role, what you do with the thyroid eye disease, these are your highest yield interventions. These are the 4 things that you really, really need to be in the back of your mind every time you look at thyroid eye disease patient. Maintain strict euthyroidism. This is the most important modifiable factor. Target your TSH, maintain it, keep them in a euthyroid state. Avoid post-treatment hypothyroidism. After treatment, surgery, or radioactive iodine, if they go into hypothyroid stage, it will significantly worsen thyroid eye disease. Smoking cessation is the strongest modifiable risk factor. Address it at every visit. Clinical priority. And then you have to be very selective and thoughtful about radioactive iodine because it can precipitate or worsen thyroid eye disease. Radioactive iodine has to be approached with extreme caution. Avoid it if you can, especially in moderate severe disease or in high-risk patients. And if you do use it, in the mild cases, prednisone and steroid prophylaxis is essential, usually started 1 to 3 days after the treatment, and it's mandatory in any high-risk criteria. And you have to be, as we talked about, make sure that we monitor the thyroid and avoid hypothyroidism. Mild disease, you'll see a lot of that. As we said, 50% of patients will have some form of thyroid eye disease. And so you will be taking care of that. You'll be managing that. Lubricate, elevate head of the bed, cold compresses, sunglasses for light sensitivity, selenium in those who are selenium insufficient. If you're not sure, check the levels and monitor the progression because mild can very well change into moderate or severe or even vision threatening. Keep checking every visit. We've already mentioned about double vision, inflammation, progression, immediately go to ophthalmology. If you're not sure it's thyroid eye disease or not, is it another ophthalmology or eye condition going on, refer so we can help with the diagnosis. And if the patient is distressed or shows any functional impairment, complains about their eyes, send to ophthalmology. But those can wait. I mean, those can be in the next week or 2. But the double visual symptoms, progressing inflammation, same day. In moderate to severe thyroid eye disease, the first line of treatment will be steroids, using IV steroids, much better than oral. You have to be careful with the cumulative dose to make sure that you don't get issues with the liver enzymes. Immunomodulators, Cellcept, mycophenolate is good as an adjunct or steroid-sparing agent. And then what has taken our world by storm, has changed our complete management paradigms, is teprotumumab, Tepezza. It's FDA approved. It's the only treatment that addresses proptosis and will help with the double vision and soft tissue involvement. It's 8 infusions over 24 weeks. In 2023, it was relabeled and it can be used in any disease duration and any form of thyroid eye disease. The mechanism is IGF-1R monoclonal antibody to reduce orbital fibroblasts. It has been shown to reduce proptosis by 2 to 3 millimeters and a 68% response in double vision. And the clinical activity scores are reduced, and patient distress is relieved tremendously. Your role as an endocrinologist is to identify those candidates, the ones that have moderate to severe, and refer them. You need to manage and monitor the possible complications, glucose and hearing, coordination as part of the team with ophthalmology, and of course, help and manage the 8 infusions over 24 weeks. Any systemic side effects, ophthalmologists will step back. We'll take care of the eyeballs, but when it comes to the body itself, that's up to you guys. We will send the patient to you for your wisdom and your help with that. Obviously, this medication is expensive, as you're all well aware. In the real world, we have a lot of constraints with that, and there's some limitations, especially in the cash-paying world, if insurance is not paying for this. And we have to be, as people living in the real world, we have to be cognizant of what the patient can afford, what they cannot, and what the infrastructure is available for IV infusion or not. And if there is a team, endocrinology, ophthalmology, and others that can work together or not to get the best results. So the core management will stay as thyroid control, smoking cessation, steroids, supportive care, and surgery when indicated the end stage, if we're constrained of using the best treatment modalities out there. For the endocrinologist, you have to monitor the glucose and the hemoglobin A1C. Do a hemoglobin A1C before you start treatment with this. Hyperglycemia occurs in 10% of patients. You have to adjust the diabetic medications, and you have been people who have developed new onset diabetes on this treatment. Hearing, 10% in trials get some hearing changes. It might be more. That's the 10% that are reported. It could be mild, it could be severe, and it could potentially be permanent. You have to monitor every single infusion, every single visit. Pregnancy, absolute contraindication. Ensure reliable contraception and monitor. Inflammatory bowel disease symptoms, elicit history of any inflammatory bowel disease. And again, screen and then ask. If they do have inflammatory bowel disease, that's a relative contraindication. And the usual infusion reactions. But this is not a classic immunosuppressant. You don't have to worry about CBC, liver function tests, or an immunosuppressive panel with people on this medication. Glucose, we talked about. In non-diabetics, be proactive. Check your hemoglobin A1C before and at the end of the treatment, and check glucose every single time they come for an infusion. Hearing may be under-recognized. We say 10%, but it might be more. Usually mild, transient, but could be persistent. And it's very significant to people that get the severe form. Baseline audiometry should be done on all patients before starting. And always ask about complaints about every single infusion visit. Any symptoms, ENT referral immediately, and the ENT becomes part of the team. We talked about what to monitor: glucose, hearing, inflammatory bowel disease, pregnancy status, and infusion reactions. There are other emerging therapies in thyroid eye disease. We have other treatments in the pipeline. We have a treatment that is in phase 3, I believe, that is right now is going to be 5 infusions over 12 weeks rather than the 8 over 24. Also, there's in development, there's subcutaneous delivery, which may obviate the need for using IV infusion. There's talks about using autoantibody reduction with FcRn. And the aim is to address the disease driver rather than the inflammation and the fibroblasts. And there is a use of interleukin-6 pathways in steroid-resistant disease as an adjunct or a second line. What this means is that thyroid eye disease, as Dr. Nada said, in thyroid treatment in general, thyroid eye disease, the treatment is shifting from supportive care to disease modifying. Multiple pathways are emerging. Treatment has to be tailored and patient-specific. And we may go from infusion-based to subcutaneous. This will reduce some of the infrastructure barriers. But again, in the real world, cost and access will always shape adoption. So thyroid control, steroids, surgery are still the mainstay and the core. Surgery, I'm not going to talk about this too much. We do it stepwise. You always do the orbital decompression first, and then you do the strabismus, the muscle surgery, and last you do the eyelid surgery. And this is done in the inactive phase. After medical treatment is done, after 6 months of stability. Your role as an endocrinologist is, number one, screen actively. Thyroid eye disease questions every visit. Do not wait for the patient to report. 2, classify which bucket are they in. Are they mild, moderate, severe, or sight-threatening? This will drive everything in the treatment, urgency, and referral. Control thyroid function, keep them euthyroid. Address smoking, the strongest modifiable risk factor. You have to document smoking cessation counseling on every visit. Refer at the right time. Do not overweight. Better to err and send them to ophthalmologist than not, and to hold them and wait on them if they're going to be severe and vision threatening. And you will be co-managing systemic risks, glucose, hearing, inflammatory bowel disease, and pregnancy. This definitely fall in the internal medicine endocrinologist domain. Final takeaways: thyroid eye disease is diagnosable. It's diagnosable in your clinic because you're often the first doctor to see it, identify it. You don't have to do imaging to suspect thyroid eye disease. You have a history, examine the relationship. Classification drives management. Mild, is it moderate, severe, or sight-threatening? Get this right, every other decision follows. Early action on your part will prevent irreversible disease and vision loss. We have treatments now. Refer them and get the team activated. You are the entry point. You're the leverage point. Thank you very much.
Thank you. Thank you very much, Amjad. Yeah, we had actually the pleasure of listening to two outstanding presentations. Thank you very much, both our speakers. Amjad, outstanding as usual. Thank you.
You're welcome.
So we have, I think, a few minutes, maybe a couple of minutes for questions. You can write down the questions in the Q&A section if you have any. If you raise your hand, that will work as well. So let's see. I'll take maybe one, and maybe Dr. Tariq can do the same. So now both speakers will be with us. Thank you. So we have a question from Dr. Sahar Qazi for Dr. Nada. So the questions are: how would we check cytokine imbalance? And regarding the microbiome, should we try to regulate the microbiome and the gut health with regards to thyroid autoimmunity? Dr. Nada?
Okay. Thank you very much for the question. So cytokine imbalance is not something we assess in routine clinical practice. While maybe it's in research study measuring cytokine like interleukin 6 or TNF alpha, they usually do, but there is no standardizations at individual level. So, and usually it does not guide our clinical decision making. That's why we not do it routinely. The second question, it's about microbiome. So the role of microbiome is an emerging and very interesting area, but currently there is no strong evidence to support routine microbiome targeting or target therapy in thyroid disease. So at this stage, we do not recommend the specific interventions beyond general health measures such as balanced diet, avoiding routine excess and maybe of unneeded diet and maybe a healthy lifestyle. That is then correcting deficiency like vitamin D. That's the main strategy, and exercise and lifestyle. So that's which general recommendations the evidence came from.
Thank you, Dr. Dr. Tariq, do you want to take the next question?
Thank you very much,
yes,
Dr.
please.
Mundir. I would like, on behalf of the Board of Directors and behalf of all of you, to thank the two speakers. Excellent, wallahi. Thank you very much. Really, excellent insights, Dr. Amjad and Dr. Nada. I don't have any specific question, but I think just a comment regarding the monoclonal antibodies. I find it always difficult actually to remember these names because they are sort of very bizarre actually to pronounce. Anyway, the cost seems to be an issue. I'm not sure this might not be a sort of an easy sort of choice. Just I would like to ask Dr. Nada, what about your experience in using the monoclonal antibodies, the Rimonabant, if I got it right, in your clinical setup, Dr. Nada?
You're
Dr. Nada, you
muted.
are muted. Just unmute, please.
Okay. So we have a shared patient between us and another institute about using, and actually it's give us a very good outcome or excellent outcome. Usually we are concerned, or maybe before we are more concerned about auditory functions, but now with our using of this, we are more trusting the agents, seeing the good response of patient in terms of the eye disease. So our experience is still for 2-3 patients. Maybe some center have more to share, but it's showing us amazing response for thyroid eye, and it's usually done through combined endocrine and eye clinic.
Dr. Munzir, do you have an experience using this monoclonal antibodies in Jordan? I know that you have a very well advanced, actually, healthcare system. And
Well,
about the cost.
yeah, thank you, but actually it's so expensive that we don't have it in Jordan yet. So yeah, so far no experience, except from our colleagues abroad or from the clinical studies. So unfortunately, no experience in Jordan. Just maybe if you allow me, Dr. Tariq, since we have several questions here.
Go ahead.
From several of our colleagues in attendance. I think this is for Dr. Amjad. The question regarding the GLP-1 receptor agonists and thyroid eye disease. Is there an association? Is any agent preferred? Maybe one is safer than others. Dr. Amjad?
Thank you. That's a great question. I'm not unaware. I'm unaware of any data or any research that really links GLP-1s with thyroid eye disease in any way, or if there's any actual direction. GLP-1s are being used more and more and more in the US. I mean, people who don't, it's a lifestyle medication right now. People who don't have a medical condition are using them for weight loss. So we're going to see more and more and more of people on GLP-1s right now. It is GLP-1s does act, we believe, on the immune system. It does have some stuff to do with the immune system, and that will be more, I believe, in your area as internists and endocrinologists to figure it out than us as ophthalmologists. But
yeah, so far I concur. I mean, I'm not aware of any data linking the GLP-1s to thyroid eye disease.
Yes.
So far so good for
the only comment I
yeah.
would say is, if you lose weight, then everything goes, you have to watch for the hyperglycemia, the titration, all the medications that they're on. And we worry about that with thyroid eye disease. So especially if they're on treatment, if they're getting the treatment, then you worry about hyperglycemia. So I would be very careful with all of that stuff.
Yeah.
Okay.
Maybe I can also add in this,
Please, yes.
as you mentioned, there is no strong, consistent evidence linking GLP-1 receptor agonist to the developmental or worsening of thyroid eye disease. However, there is maybe some isolated reports and theoretical concern about particularly related to rapid weight loss or metabolic shift of those patients, which could maybe potential influence autoimmune activities, like just about the rapid weight shift itself, not the agents. And maybe that's what we need to highlight. But currently, as we know, it's not contraindicated, but it would be used with caution in patients who have active or unstable thyroid eye disease.
Thank you, Dr. Nada. Last question from Dr. Zain Al-Ma'ani. The question was regarding ototoxicity with the immune modulators, Dr. Amjad. Is it reversible, the ototoxicity?
So in our center, in the last 5 years, we've done over 56 patients with us, 56 patients. Not a single one of those patients had permanent auditory loss. We've had 4 people that developed symptoms, tinnitus, and some visual hearing loss, and we stopped the treatment as a precaution. And then over 2 to 3 months, the symptoms went away and they recovered. And one of them went back and insisted on using the medication again because she had such good relief of her thyroid eye disease. And the auditory did not come back. So that was very interesting for us. But obviously, the literature is the literature. 10% auditory changes. We may have been just lucky. Statistics are statistics. And I'm sure some people have permanently lost their hearing. But I can tell you that this is, for some people, especially, thyroid eye disease and losing vision and maybe more of an issue for them than a hearing loss. So that's something that is a patient by patient, has to be discussed with them, and with appropriate informed consent, you can decide what the proper treatment is.
Okay, thank you very much. I'd like to maybe conclude by again thanking our excellent speakers, Dr. Nada, Dr. Amjad. Thank you very much, Dr. Tariq, for giving me the opportunity to co-moderate with you this evening. To all our attendees, again, thank you very much for giving us the time, and inshallah, we're looking forward to seeing everybody in the Arab Thyroid Association Congress in 10 days. The discount offer is still on until midnight tonight, so please take advantage of that. And we'll see you in the next webinar, inshallah. Thank you very much, and good night all.
Thank you, everybody. Thank you so much.
Thank you, everybody. Thank you, Amjad. Thank you, Nada. Thank you, Khalid and the team. So looking forward to see you all in the next activity as well as in the Congress. Thank you.
Good night. My pleasure. Ma salama. Bye-bye.
Thank you. Assalamu alaikum. Bye-bye.